Hello, hello, hello. I know it was a short one, so I do apologize for that. And hello, everyone. Let me know how my mic sounds. It says it's working, but it doesn't. Thank you, Ms. Mills. Ms. Mills said, your mic sounds nice. Check one. All right. So, hello, hello, hello to my team, Mr. Sandeep, Ms. Mills. I imagine Miss Haley will be in here soon. Miss Beth. Hello, hello, hello. Welcome, welcome, welcome. And I also put Miss Beth in the team because she is a part of the AMCI staff as well. So just want to say hello. And also the interns, Miss Beth, Miss Vina, Miss Case. I see you. Let me see. Is there anybody else? I'm missing my Star Wars girl. If you pop in, hello to you. And hello to you, coders. This is the last class. What do you have to say? Go ahead, type in the chat. How are you feeling? You feeling confident? Let me know. Look at Troopty. Hi, how are you? Look at Miss Beth. Uh. Yes, Miss Haley. Miss Haley said time has flown. What? Oh, we're going to be offering more classes next semester. I hope next semester. The target is to offer it to I2MC. I know. Well, why don't you know? Well, I want to, but I got a surprise for you all. I got a surprise. All right. So, hi, Lucky. All right, let's go. I'm going to let you in on a surprise in a minute. All right, it's week 16. What are we going to do? Well, we're going to keep it moving and we're going to talk about evaluation and management. But the purpose of class, if this is your first time here, let me know. Type in the chat. And just want to let you know the purpose of these classes are not to instruct, but to hold you accountable. We want to be accessible to you. That's why I'm saying, hey, what do you think? What do you feel? Type in the chat. We have a lot of instructors and highly qualified interns in the chat who can help you. No doubt about it. Also, we want to review what you should already know, give you tips on how to navigate your course, and point out key guidelines. There are no new announcements. We're going to keep on going. Yeah, we got a lot of stuff to talk about today. All right. So if this is your first time here, or if you've been coming and you haven't registered for the YouTube course, go ahead to our website, www.amcicoding.com, click on YouTube course, and go right here. Fill out that enrollment form. We will keep you informed. Indeed, we will inform you on what's going to happen next. If we do anything next, it will be the I2MC course for 8 weeks. That's it, I2MC. And then we'll start all over. All right. I want to keep you all engaged because you all did a phenomenal job. The feedback has been really great. So why not? Also, um, if this is your first time, this is where you can get the syllabus. All of the assignments are here. All right. Now to RSVP for class don't matter, right? It doesn't matter. So you still need to know this is week 16. You just click on this link. And as you can see, it's very simple. Click on the notify me button and definitely don't like it down. Excuse me, like it down. Don't down like it and up like it. Sorry about that. And also click on that bell for notifications about the next classes. We do have classes on Monday night that will help refine your ICD-10-CM guidelines, and Friday, CPT. ICD-10-CM with Miss Haley, CPT with Mr. Sandeep. All right, the textbooks for this class today, we're pretty much just going to use your CPT manual. I don't even think we're going to use the MCG, but the charts, the E&M charts are in the MCG manual. and also how to get on Discord. That's in your syllabus. So why join Discord? Because there are additional resources like practice questions. You have access to AMCI instructors and interns daily. There are private classes in there like test taking anxiety, IMTAP, and Friday Night Live. So definitely join Discord and you can access it with the instructions from your syllabus. All right, so now that we've completed the 16 weeks, it's now time for you to exam prep. If you're taking the CPC, I would go at the bottom of the syllabus, the instructions for CPC exam prep. Definitely follow them. Also, if you're taking the CCSP, at the bottom of your syllabus, go to the bottom and follow the instructions to take the CCSP. If you are needing more, like you want more instruction, you just say, hey, I just need more and I want some of that AMCI private stuff, I would go into the AMC a la carte courses and see if there's something that you want to do. Now, for CCS, I do recommend that you take this CCSP exam prep class and boot camp. I recommend it because it's more information directed at those um, 5 domains. All right. So you got to have the 5 domains under your belt. Not a whole lot. And you can do it on your own if you get the book that is recommended. Also, if you're planning on taking the CCS, I recommend this facility medical coding course with boot camp. Definitely 5 domain instruction. And no, I do not recommend taking the CCS after the 16-week course because you need the instruction on the 5 domains, which includes PCS coding. All right, so now let me just take a pause. We'll take a pause. Does anybody have any questions? So someone said same time. If you look on your syllabus, the times are there. So class is either at 12 noon or 7 p.m. Great question. All right, so if you have questions, type them in the chat. Now, let's go ahead and look at the syllabus. This is what we need to have completed before today's class. And I get it. We all don't have time to, but this is what you should have. And also, um, I'm not going to go over all of them. The only thing I'm going to point out is your AAPC E&M calculator. I did place it on your syllabus. So it will make sense after today's class. But this calculator is how you calculate or score your evaluation and management scenarios. All right, so we'll talk more about the calculators, but now I want to revisit a mistake that I made last week. One of our interns, Miss Vina D. Yeah, I'm calling you out because she's forensic. And you know what? That's a compliment. So anytime I have that opportunity, I love to take it. She said, hey, Mrs. J, you made a mistake. And she's spot on. We had this scenario last time where this patient, 4-year-old patient, presented to the pediatrician for routine immunizations and a vaccine, right? And it turns out this patient had a DTaP, an IPV vaccine, as well as the MMR vaccine and the influenza vaccine. Oh, wait. Okay, so when you have a circumstance where the patient is 18 and under, and you have counseling, as was our circumstance, you code not the number of vaccines, but the number of components. Now, we got that right. Where I made the mistake, for every single vaccine, you code the first component. Excuse me, not vaccine, immunization, excuse me. For every single immunization, you code each first component of each immunization. What does that mean? That means so if you have a DTAP, this is diphtheria, um, tetanus, and acellular pertussis. So acellular pertussis is one. So you count all of the components. So diphtheria is one, tetanus is two, and acellular pertussis is three. So there are three components. IPV, that's inactive polio vaccine. So this is one vaccine, so therefore it has one component. MMR is the measles, mumps, and rubella, right? Vaccine. So there are three. So you must, for the first code, that first code, like 90460, you have to code each first component, the first component of each vaccine. So we needed one for diphtheria, one for IPV, and one for MMR. And I made the mistake by not selecting C because C is coding 90460 times 3 for each first component. I think this might be wrong. Let's see. 94630, this needs to be 3, and this needs to be 1 for component for tetanus, 1 for acellular pertussis, so that's 2 additional. IPV, um, you don't code that because this is just one, so that's two. In MMR, there's only two for measles and rubella, excuse me, mumps and rubella. So that's two remaining here, two remaining there. So this is four. So the correct answer would be 90461 times 4. Now, I left it the way it was originally so you can see it, but the correct answer would be C, 90460 times 3, because you have to code each first component, and all of the remaining will be coded with the add-on code, 90461. So you might say, Mrs. J, I could understand that if I saw the code. So here is the code, 90460. This is the first or only component of each vaccine or toxoid administered. And 90461, this is each additional vaccine or toxoid component administered. So the moral of the story is you just have to know the components, the number of components when the patient is 18 and older and has counseling. If they don't have counseling, it's easier. Just code each vaccine. If they're older than 18, it's easy. Just code all the vaccines. All right. I just want to know, did that make sense? Because I spent a lot of time on that and we need to go. So type in the chat. Hello, Brenda. Welcome to class. All right. Now let's get going. Hi, Lucky. I see you. Now let's go ahead and talk about week 16. We're going to talk about E&M. So what should you know? What should you know for this week? You should be familiar with the E&M guidelines on those green pages right before the E&M codes in your CPT manual. You have to know that you apply those general coding guidelines unless there's a specific or parenthetical guideline that supersedes it. And you should be familiar with E&M calculator tools. Now, I want to know, coders, type in the chat, have you used your E&M calculator tool? And if you're an intern, I want to know if you've used it. Yeah, there's one in your LMS. So let me know. All right, someone says no, so this will be a new experience. Come on, talk to me, code. Come on, coders. I gotta know. All right. Wow. So Vina, you took your exam. So you mean to tell me you took your exam without using the calculator in your tool? Let me know. That's really interesting. So you just scored everything manually. And that's exactly what an AMCI, trained student could do. So did you see the tool when you took your CPC exam? And if you didn't know, Vina took hers, I think a couple of months ago or last month. No, a couple of months ago. And so she has the most fresh information. So I just am asking her just small things, not anything about the questions, because that wouldn't be ethical. Number one. Number two, we don't need it. I know you all are prepared. All right. So, yeah. So Vina said, "Hey, I just like scoring it myself. Outstanding, outstanding. All right, so now let's talk about chunning. When you chun the evaluation and management section, it is not the same. No. So as you can see, I just took a screenshot of our MCDC. They have like a video that shows them how to do it, but this is basically how you chun the E&M office and other outpatient services section. It's just important that you document really, just you're able to see what type of medical decision making it is. So it's straightforward and 15 minutes. Straightforward MDM, and the time is 15 minutes. And 99203 low MDM 30 minutes. So that's the way. That is the method that we use to um, chun. And if you need, more visuals, I would encourage you to join the chun group on Facebook. All right, you can see all of the instructors. I mean, not instructors, the students chun, and it's really good too. All right, so just to let you know that CPT is copyright of the 2026 AMA, all rights are reserved. Keyword concept, FTR, Chun, AMCI Fab 7, AMCI ICD-10 CM Flip Tap, and MCG are trademarks of AMCI. The credentials, CPC, CRC, COC, CPMA, CPB, CPPM, CPCO, are owned by AAPC, and the credentials CCA, CCS, CCSP, RHIA, RHIT are owned by AHIMA, and AMCI does not own the rights to these credentials. Now, let's go ahead and test your knowledge. I want to know, what you already know about evaluation and management. So, here we go. True or false? If a patient is an established patient of the small town family practice LLC, and the patient may see any physician in that practice and the visit will be considered established. True or false? What say you? Type your answers in the chat. Okay, what do you say? All right, we got one, two, three. We got one, two, three, four, five. Okay, I'm going to move a little faster, all right? The answer is true. Answer is false. I apologize. The answer is false. And the reason the answer is false is because the physician that this patient sees must be of the same specialty, and subspecialty. So some family practices, they have multi-specialties, physicians. So if this patient physician or doctor is a family practitioner, they have to see family practitioners. They can't see um, a another doctor. Let's say they have a doctor in there that is a family practitioner that specializes in oncology. So it must be the same specialty and subspecialty. So this would be false because you can't see any physician unless there's same specialty and subspecialty. All right, good job. Hey, you learned something. Don't be mad at yourself. You learned something. All right. Dr. Jones, an oncologist from Capital Physicians Group, let's say group, admitted his patient, Ms. Jones, no relation, after having a reaction to chemotherapy. The next day, Dr. Brown, an internist from the same practice, visits Mrs. or Ms. Jones. The practice will bill Dr. Brown as a new visit. True or false? Somebody hit that fast. That's right. Health messages. She said, boom, boom, boom. And someone said, hey, I assume all of the doctors were of the same specialty. You know what? We're not going to assume nothing. If it's not written, right? It didn't happen or it doesn't exist. That is a fantastic um, post. Thank you so much for posting that. All right. So those answers are coming in. That's right, Miss Haley. Lightning speed. Boom. It is true. Absolutely. These doctors are not of the same specialty and subspecialty. So therefore, the practice will bill Dr. Brown as a new visit. New. But if they were of the same specialty and subspecialty, it would be a subsequent visit. All right, true or false? This is our final one. A patient has an annual visit, and during the visit, the tests reveal that the patient has diabetes. The physician will bill for both the annual visit and the sick visit. And I want to add to this. Let's say the physician worked up the sick visit and did carry out the annual visit. Can the physician bill for both? True or false? Go ahead, put your answers in the chat. Don't be afraid. And thank you. I like all answers. Okay, somebody said ahead of time. This is going to be an aha moment. I know that's right. True or false? What say you? Hello, Sue. Hello, Yvonne. Hello, Janet. Hello, B. Frazier. Hi, Tanya. All right. Hey, Brenda again. All right. So these answers are, people are a little, I think you guys are all saying the same thing. And the answer is true. Yes. If that physician works up that second diagnosis, absolutely, it is true. You will code both, and one will have the modifier 25. The sick visit or the diagnostic, the one with the diagnosis, will need that modifier 25. That's right, Ms. Vina. Well done. Well done. Hi, Yvonne. Okay, that was it. Good job. This is a good warm up. Now, I want to look at the E&M charts. I want to look at the table of contents, and I want to look at those guidelines. And if you didn't know, these little charts are in the front of the E&M station, section. And definitely use it if you feel you need to. I'm not going to review how to in my lectures. I do, but I just want to remind you they are there. And also make friends with your table of contents. This, I think, will help you just kind of get an idea of the locations, what's going on where. So definitely do that. Also pay attention to those asterisks because it says, hey, there are coding nuances associated with it. So pay attention, make friends. Now let's get to the good stuff. I want to get to the guidelines. No, I'm not going to review them all. You should have reviewed them before class. And also, if you didn't, you can. And you will be directed on your syllabus to do so. But I do want to tell you this. These green page guidelines are specific to only the following encounters: your office visits, telemedicine visits, hospital observation visits, consultations, ED visits, nursing facility visits, home or residence visits, and prolonged services. So that's what these guidelines are pertinent to. And I got that information from right here. Okay. Yeah. So these guidelines don't pertain to all evaluation and management. No. And another thing I want to point out to you that the guidelines for multiple evaluation and management services on the same day is here, separately reported services, and also history and or exam. And definitions, these definitions are very, very important. And anytime you have these circumstances and you're not quite sure, definitely reference the definitions. Okay. And on these pages, you have guidelines for selecting the MDM. Now, that is going to be the basis of our discussion today. This selecting the medical of decision making, the level of medical decision making that the physician used. I don't know why we're not being able to see anything. This happened before, so maybe I'll try it. I'll try and see what's going on. Come on now. I don't know why that's like that. We're gonna try it. Okay, let's try. Okay. Oh, it's just not, it just doesn't want to work today. Okay, there you go. All right, so let me try and go back to this next one. So it's just really good to make friends. And the level of medical decision making, this is, kind of important. And the definitions underneath, you'll get the definitions of the problems, the data, see your problems, your data, your risk, etc. So I recommend that you read it if you need it. Hopefully, this session today will help you. And also, this is the information on how to score the MDM. So go ahead and type in the chat and let me know how comfortable you feel about scoring that MDM, those problems, those data, those risks in your documentation. And if you don't know what I'm talking about, say that too. Say, I don't know what you're talking about, Mrs. J. But while you're typing in the chat, I want to let you know that the problems, data, and risk definitions are in these green sections. Also, the guidelines for how to select a level based on time is in this guideline as well. All right. So what to do when you have an unlisted service and how to utilize that special report is also here. Nobody said anything. Someone said somewhat. Okay. Okay. I'll take that. But come on, help me out. Help me help you. All right. So now someone said they're confident. I love it. I love it. And you do have a tool. You got a tool if you're taking the CPC exam, and we're going to talk about that tool. Someone, Vina, and I'm going to call you out. She said, "Hey, I was confident in my scoring, so I didn't need the tool." That's what I'm talking about, AMCI student. They sure are confident. All right, so we've got E&M tools. What is an E&M tool? Well, it's a calculator used to score your E&M encounters. And this is used on the CPC exam. Now, if you're taking the CCSP, they don't have a tool that I'm aware of unless they have one starting May 1st, which is tomorrow. Right now, there's no tool. Okay, somebody said also oh no, somebody said they're confident they're going to mess it up. No, you're not. Look, after today, we're going to rock it. Okay, so AAPC has a calculator and it's free. And I put the link on your syllabus for that calculator. So definitely use it and start scoring. Start practicing if you want to use it. But if you want to do it by hand, you know, do it. I know I would do mine by hand. The link is on your syllabus if you want to use the calculator. And also, in the 16-week playback, not today 16-week, but the 16-week from the full course from previous. Now, this is not the same type of course. This one just kind of augments, that one. But that 16-week playback, it's on your playlist. I do a demonstration of the find a code calculator, right? So I just want to let you know that's find a codes and it's on the 16-week playback. All right. Just want to let you know that. And then AMCI students, you will have a calculator in your LMS. Yeah, next session. And I can't say anything more than that, but it is coming and we've got a fantastic surprise for you. And it's my opinion, it's the best because it's modeled after the AMCI PDR chart. Just saying. So it is phenomenal. All right. So speaking of PDR, what is PDR? PDR is problems, data, and risk, right? So essentially, to use the tool is going to score the amount of problems, the complexity of the data, and the number of risks to a patient, you know? And we get to determine the level of professional services and ultimately that code selection when we score the PDR, the problems, the data, and the risk. But there are two ways to to determine the level of service. One, scoring the PDR, or two, the time. When you take your medical coding exam, you will be able to demonstrate knowledge of how to score the MDM, the medical decision making, by using this problem, data, and risks, or the time. All right. So now my focus right now is to have a clinic on mastering these problems, data, and risk. And I think that I've seen a little bit of confusion because students just were not clear about which one should I select and which, where does it belong? You know what I mean? Where would this diagnosis belong? Right? Yeah. And you still, even though you're using a tool, you still have to know and be able to identify the problems, the data, and the risk. So let's do it. And then after you know the problems, data, and risk, that tool will just be light work. And I think Vina just kind of says it. Once you identify the problems and data, you can just go ahead and score it yourself because that's the easy part. So let's go ahead and figure out how to get the number of problems, how to determine the amount or the amount of complexity of the data and the overall risk of the patient. But first, let me tell you what does that number and complexity of problems, what does the problems represent? Well, pretty much what's wrong with the patient. Yeah. What's wrong with the patient during that encounter, right? And the data is what the provider reviews, what they order, what they analyze, and what they discuss. The data. And what's the risk? What is the risk to the patient? What is the risk of that provider's decision making? What risk will it have to the patient? That's your PDR. You all with me? We're quiet. Okay, so I'm just going to chalk that up as you're paying attention and you're locked in. All right, so now let's focus on problems. So what is the problem? Problems are what is wrong with the patient, right? What's wrong with that patient? That's it. And there are levels of problems. You have minimal problems, you have low problems, you have moderate and high. One of the four. So what's an example of a minimal problem? Well, a cold, insect bite, mild rash. That's an example, or yeah, examples of a minimal problem. Now, low, theirs are a little more, a lot, well, some little more, but controlled hypertension, that's a low problem. Yeah, it's in control. A urinary tract infection and a sprain. These are examples of low problems. These are stable or chronic or simple or acute, right? But the key is it's in control. Now we move from low to moderate when you see stuff like worsening or multiple conditions. Some examples are uncontrolled diabetes, yes, COPD flare up, pneumonia. Yeah, so these are definitely more complex, and we're still in the moderate range. Now we're in the high range when it's life threatening or severe. Some examples are sepsis, stroke, and myocardial infarction. So these are examples of problems: minimal, low, moderate, and high. Now let's turn our attention to data. Remember, data is something that the provider reviewed. It's data that they reviewed or ordered, analyzed, or discussed. And we have the same four categories. Minimal is the same as straightforward, right? So you have minimal data when there's no labs, no imaging, no records, no nothing. And my gem is if there's no data, no decision support, if nothing was reviewed or ordered, you're minimal. Now let's go to low. Some examples of low is when you're reviewing some tests, but one or two tests. You're ordering tests, one or two tests. So essentially, your ordering alone keeps you low. If it's simple and limited, it's probably low. Moderate data. Moderate is when you have multiple elements or you have some external involvement. External involvement means an external physician helped with the data. An external historian, somebody other than the patient, gave history, etc. So essentially, when it's moderate, they're reviewing external notes, they're reviewing of multiple tests, they're ordering multiple tests, and they have an independent historian. So when that's happening, it's typically moderate. Also, high data is advanced analysis or when this doctor is collaborating with another doctor. Some examples are There is an independent interpretation of a test. This current doctor can't do it and says, hey, I want this doctor to look at it. So that's an independent interpretation of a test. And you know what? Not separately reported. So you can't, you know, send it out to a physician for interpretation and they bill for that. No, it's not that type of interpretation. It's just pretty much they're looking at it, they're giving the opinion, not providing professional services where they're going to, um, you know, issue a bill for it for their services. And also discussion with another physician or um, qualified healthcare professional. So it gets more intense when it's high data. However, the PDR chart really helps keep you focused on where that data should fall. I think that's the best part of that PDR chart because the data to me is spot on. Also, finally, the risk. The risk is or are, you basically have to determine what is the risk of the patient expiring or dying because of the provider's decision. So, what is the risk? Is it minimal or straightforward? Well, when there's little risk of morbidity and no meaningful intervention is needed. And some examples are, hey, just go home and rest and take fluids. And the doctor just assures you there's no treatment or no additional treatment required. So that's minimal risk. Low risk is low probability of minor morbidity. So pretty much care, but conservative care, like recommending over the counter medications or even physical therapy. Yeah. So that is a low risk. Moderate risk. This is a moderate risk of morbidity, and it does require some management decisions like prescription drug management. And yes, writing a prescription is an example of prescription drug management because providers, doctors have to think they have to use some level of expertise before they issue a prescription. They do. If a patient has multiple comorbidities, allergic to this, you know what I mean? They have to think. So yeah, it is moderate. Also, minor surgery with some risk factors, elective major surgery, no risk factors falls under moderate, and social determinants of health impacting care. That's when someone has a circumstance that may impact them getting care. Let's say the patient is a female, a in a domestic violence situation, and the husband is prohibiting um, you know, medication. So it could be anything, any social determinant that impacts their health. And finally, high risk of severe morbidity or death. And examples of that would be the necessitation of the patient being hospitalized, also emergency surgery, and drug therapy requiring intensive monitoring. So, whenever that is going on, we do consider these high risk. And if the patient's life or organs are at risk, and even body parts, it's high risk. So if you're at risk of losing your eyesight, at risk of losing a finger, etc., it's all high risk. And of course, your organs. Now, after you assess whether it's a problem, the score of the problem, data, or risk, now you have to level it. You have to score it, not level it. We don't say level anymore because they're not leveling. Now we're scoring it. And the way you score, you pretty much throw out the lowest code the next. Throw out the lowest eligible code the next. And that's pretty much it. Now I want to know, are you ready to test your knowledge? We want to test your knowledge if you can understand the problems, the data, and the risk. We are not testing coding. We want to know, can you identify the problems, data, and the risk? What's wrong with the patient? What did they analyze? And what is the patient risk? All right, somebody say, I'm ready. Okay, Carmen, let's go. Let's do it. All right, so I do have a clipping on the right. This is the AMCI PDR chart. So if this is your first time seeing it, the first column is for problems, the second data, the third risk, and the last are the codes that you should select. Should you select a straightforward or low? The moderate and high are not here. Look at this. Look at my answer here. But it's okay. All right, so we have I want to know of the following answers, which best describes the problem? Is this a straightforward, a low, moderate, or high? We have a 25-year-old presents with a sore throat and a mild fever for 2 days. The provider performs an exam and diagnoses viral pharyngitis, recommends rest, fluids, and some over the counter medications. No labs or imaging were ordered. Okay, coders, what say you? Go ahead. All right, so what I'm going to do is I'm just going to kind of walk you all through this because the answer's there. So pretty much you need to, we only have one problem, and the problem is pharyngitis. We do have some indicators. This patient had a mild as sore throat and a fever for 2 days, but we have pharyngitis. And I'm going to tell you, in the future, you should always write down everything. Write down all problems. Write down the signs and symptoms. Write down the diagnosis, and you're going to see in previous, excuse me, not previous, but subsequent scenarios why you should. But I kind of set this one up just for a demonstration, not really for you to do it. And I'm just letting you know that because it's not, um, because you'll see why, but I only left pharyngitis because that's what we need to focus on. The signs and symptoms really are more pertinent when you have more um, complex diagnoses. I'll show you. All right, so pharyngitis is what I'm focusing on. The doctor said this is what you have. You need to go home and rest. And pretty much this problem is straightforward. Here's why. Because it is one self-limited or minor problem. It is not low because it's not a chronic illness. It could be chronic if the physician says it is, but this seems like it's just lasted 2 days. Now, chronic illness is something that lasts a month or longer and expected and could possibly um, last for the duration of the patient's life. So this, in this case, is not chronic. Now, this is an acute illness, right? So let me look and see if it falls under this acute. Like, is it one acute, uncomplicated illness or injury? Hmm. Uh. Mr. Sandeep, I want to know what you think about this. Do you think this is low or minimal? Or Mr. Sandeep might be resting. No, I'm just kidding, Mr. Sandeep. I know you're here. But I'm gonna give it low because the doctor said, hey, you just had a mild fever, you had a sore throat, pharyngitis, and that's just inflammation, you know. So I'm not going to even give it an acute. It could be. So if you think it's acute, and this is subjective, coders. If you think it's acute, give it low. I'm going to give it minimal because chat did, so I'll just stay with chat. But Mr. Sandeep might say low. For the sake, let's just say some of you say low, I say minimal. So I'm going to say it's straightforward. Keep your answer, okay? Keep your answer. So I'm saying straightforward. All right, now let's go to data. Data. We want to know how much data, what was the complexity of the data? What did that doctor analyze, review, etc.? So essentially, he said there's no labs, no imaging, no historians, no physicians, no nothing. You know what? That's pretty straightforward. And that is the answer. So that data is straightforward. Let's give it that. So I say straightforward data, straightforward problems. Now let's go ahead on to the risk. And the doctor said, hey, you can take some over the counter medicine if you need to, but the doctor didn't really prescribe any medication. It could be low or minimal, right? So I gave it straightforward, straightforward, straightforward. And my result is a straightforward MDM. However, if you said this is low, because you could, this is acute, right? It's just been happening 2 days ago. And it's happening right now. That's acute illness, so let's say low. And let's say that the data is minimal and the risk is minimal. Do you all agree minimal risk? It's still straightforward, right? Still going to be straightforward. So that's why you all shouldn't like worry like, "Oh, I'm going to select the wrong answer." Right? You're going to say, there is some leeway. Is 9 times out of 10 you're going to have, yeah, somebody said it's a sore throat. Yeah, that's essentially what it is. So I gave it minimal. If you even said it was a low problem, you still should have come out and said this is a straightforward MDM, right? Because you would have thrown out the lowest, coded the next, and you still are at straightforward. So good job, everyone. Good job. I want to try again. Yeah, let's try this again. All right, so we're going to, of the following answers, which best describes the problem? A, straightforward, B, low, C, moderate, D, high. We have a 68-year-old patient, 68 patient with sepsis who presents with fever, hypotension, and altered mental status. The provider orders 3 unique labs and imaging, initiates IV antibiotics, and admits the patient to ICU. So we have to figure out the problem. We're not thinking about nothing else, just the problem. So do you think this problem is straightforward, low, moderate, or high? All right. So look at that. You guys are coming through. And you know what? You are absolutely correct so far. They're saying, hey, this is high. You know why? Because here's my inventory. We had sepsis, we have fever, hypotension, and altered mental status. So that means that this is high. Why is it high? Well, it's not moderate, and here's why. Sepsis is a diagnosis that could cause, it's a diagnosis that could cause death. Yes, sepsis does not play. It happens very, very rapidly. And, well, the decline does. And let's just go ahead and test it up against the problems in the moderate section. It says one or more chronic illness with exacerbation, progression, or effects of treatment. I wouldn't say that this sepsis it is chronic, yes, but I think we can go further than exacerbation, progression, or effects of treatment. We don't have anything that says this is exacerbation. So I'm looking for this language. And we do have two chronic illnesses, right? Hypotension and sepsis, but I don't see this being stable. Let's go further. One undiagnosed new problem. Well, sepsis has already been diagnosed. It doesn't fall in there. We have one acute illness with systemic symptoms? Well, we do have one acute illness. We do have systemic symptom because fever is a systemic symptom. And while we're talking about systemic symptoms are symptoms that affect or impact the whole body. So fever, fatigue. Anybody have any other examples of systemic um, symptom? Malaise. I guess malaise is fatigue, right? All right. So I'll think of some. But in the meantime, that is a systemic symptom. But I need to go to the high. I need to go to the high because it could be number one, right? Like progression. I don't know. It could be um, number, it could be, in the moderate, but I think we can look at this high and get something more. And one or more chronic illnesses with severe exacerbation, progression, or side effects of treatment. We haven't confirmed any exacerbation, but I like this right here. One acute or chronic illness or injury that poses a threat to life, and sepsis does indeed. So I'm going with high. High is my problem, P. Now, let's turn our attention to the data. All right. So the data, what do we have as data? Well, it says that there were 3 unique labs. While the doctor didn't specify the labs, I'm going to give them that. I'm going to just say, all right, there was 3 unique labs and imaging. So I'm going to say there was 1 image. So where do we fall? Do we fall in the high? Well, let's take a look at this tool. It says at the top, each unique test order and documented contributes to a combination of 2 or 3. So what does that mean? It means you must meet the requirements of at least 2 out of 3 categories on this list. So category 1 is here, then down category 2 or category 3. So let's look at category 1. Do we meet it? Well, it says category 1 requires tests, documents, or independent historians, any combination of 3. So if we look at the first, it says review of prior external notes from each unique source. Well, I don't see any mention of notes, so I'm going down. Review of the results of each unique test. Well, it doesn't say he reviewed it, but it does say they ordered each unique test. In each unique test, we have 3, 3, and we do have a combination of 3. So we do meet category 1. So we have a total of 4 because we have 3 tests and 1 image. So that is 4. Now I'm going to look down to category 2 to see if there was an independent interpretation. No mention. Category 3, was there a discussion of management of test interpretation with an external physician? There's no mention. So if it doesn't meet, we got to fulfill 2. We've fulfilled category 1, but we don't fulfill categories 2 or 3. So now let's go up to moderate. And we know, and this is similar, moderate is exactly like high, but the requirements are not the same. All you have to do is meet any one of the categories, and we've met category 1. So this is moderate. So the result is moderate. Remember, the problem was high, the data is moderate. Now let's go to the risk. And essentially, this patient was hospitalized in the ICU. So we're going to go look in this category, and I'm going to say it's high because right here, decision to hospitalize or escalate hospital level of care. And the hospital level of care was ICU. This is indeed high. So our problems are high, our data is moderate, our risk is high. So I'm going to get rid of the moderate data because I'm throwing out the lowest. We're going to code the next, and the result is high. Good job, good job, good job. Okay, coders, I'm going to pause for a minute. It is 1:02, and if you have to leave, I definitely understand. I have one more to go, and then I'm going to show you the AAPC calculator. You don't necessarily, we don't have to do it, but I want to show you. And if you have to leave, I understand. I should be about 15 more minutes. So, and also I want to check on you. How do you feel? Thank you, Mr. Sandeep. Mr. Sandeep gave a good definition of acute or chronic illness or injury that poses a threat to life or body function for those of you that couldn't see it. All right, so the answer is high. Let's try one more. All right, of the following answers, which best describes the problem? A 54-year-old male with uncontrolled type 2 diabetes presents with fatigue and elevated blood glucose levels. The provider determines that insulin therapy is indicated. However, the patient is homeless and does not have access to refrigeration or consistent meals. So the provider adjusts the treatment plan to oral medication and coordinates social support resources. The provider documents that the patient's living situation is limiting optimal treatment options. Okay, coders, go ahead and tell me what you believe the problem is. Is it straightforward, low, moderate, or high? Go ahead, type your answers in the chat. Someone said they feel great. I love it. I love it. I love it. Good job, Sunita. Good job. And it's good that she answered. Not saying that her answer is correct, but good job. Okay, come on, coders. What say you? Good job. Gabenja. Gabenja or Gabenga? Good job. That's what I'm talking about. Answer that question. Don't be afraid. Because remember, this is subjective. The problems is subjective and the risk is too. Good job, Brenda. Let's go. All right, so keep them coming. Keep them coming. Great job, Jared. Meredith. So I'm going to, a lot of you said moderate, so let me go see what you're talking about. Now let me go ahead and inventory my problems. We have an uncontrolled type 2 diabetes mellitus, elevated blood glucose, and fatigue. All right. So where do we fall? Is this one or more chronic illnesses with exacerbation, progression, or side effects of treatment? Somebody might say yes, but I don't see any exacerbation. Yes, uncontrolled, but uncontrolled doesn't mean exacerbation in terms of that definition. So let's move on. This patient has two or more stable chronic illnesses. Nope. Fatigue is not considered chronic unless the doctor has diagnosed it. So this pretty much is a systemic issue. It's a systemic symptom. Now I'm going to go down. One undiagnosed new problem. Nope, we're already diagnosed. This patient has uncontrolled type 2. Let's go down further. One acute illness with systemic symptoms. I guess it is acute. I guess it is acute because it's uncontrolled. That's the acute problem. It's happening now. So I would say it's one acute illness with systemic symptoms. That's my vote. Mr. Sandeep might say, hey, I think it falls more in a chronic illness with progression. I don't know. But according to the definitions, I think it falls because this is happening right now. It does not fall under high because I'll tell you why. Let me see if I have a definition. I can't really see the high. I can't see it. Yeah, here it is. I can see it. All right, so a it's not considered. You know what? I cannot see this. Let me try and pull this down. Give me a moment, please. It's not considered high. It's because high, it has to be one or more chronic illness with severe exacerbation, progression, or side effects of treatment. I'm not sure if it's severe. It is uncontrolled, but the doctor has to say that. I can't say it. And it's not an acute or chronic illness or injury that poses a threat to life or body functions. And we're talking about the doctor's treatment today is not going to pose a threat to life. So that's why it's not high to me. So I'm going to give it moderate. That's moderate. All right, so we got a moderate problem. Now we're going into the data. I'm going to look at this data and pretty much, did they analyze glucose levels? It doesn't say. It's an assumption. But you know what? I'm going to give it straightforward. Yeah. I don't know why that says moderate. I'm giving it straightforward. See? Straightforward. Get yourself up there. All right, so we have a moderate problem and a straightforward data. Now let's look at the risk. And the risk, okay, coders, what do you think the risk is? Type in the chat. Go ahead. Before I go to the next page, what do you think the risk is? Yes, look at that. B. Fraser is spot on. Okay, she gave it away. I gave it away more. All right. So, yeah, it's moderate. And the reason it's moderate is that although they recommended insulin therapy, the patient has no refrigeration. So, social determinants of health, limit their ability to receive the optimal treatment. So, right, let me see one of these say it. This last one, diagnosis or treatment significantly limited by the social determinants of health. It's going to be moderate. So we've got moderate problems, straightforward data, moderate risk. So we're going to throw out the lowest, code the next, and our answer is moderate. All right, coders. So hopefully this helped. Hopefully, just kind of get you familiar with looking at this PDR chart, really making decisions based upon just looking at the documentation, abstracting what is necessary and selecting the medical decision making, the MDM. And I'm going to tell you this, coders. In the real world, if you master the medical decision making, you will be an asset to any company that you work for because it's very easy to just say, I'm going to select the time, but your provider is probably eligible for more and you have the ability to select the correct code based on the MDM. And that's so much revenue that you'll be able to get for your provider. It's easy to select time. It takes more skill to select the MDM. Good job. Good job. All right, so I just want to kind of look at this. I want to use the tool, right? But I do have a scenario here, and this scenario is it's more extensive, so I'm going to read it. I'm going to abstract the P, the D, the R, and then I'm going to go to the AAPC and use their calculator. All right. So we have a 58-year-old patient with a history of type 2 diabetes mellitus, CKD stage 3, and hypertension. Presents with worsening fatigue, lower extremity edema, and dizziness. Current medications include insulin, lisinopril, and furosemide, and the patient reports recent episodes of hypoglycemia and lightheadedness suspected to be in relation to the medication effects. The provider reviews external nephrology records, prior hospitalization records, and recent lab results, including a CMP, comprehensive metabolic panel, HbA1c, that's your A1c, and renal function studies. Additional evaluation includes ordering repeat CPM, BNP, and urinalysis, and the provider discusses the case with the patient's nephrologist to coordinate care. Based on the findings, the provider adjusts insulin dosing, modifies diuretic therapy, and initiates close monitoring due to the risk of electrolyte imbalance and renal function decline. Okay, coders, does anybody want to just say what the code is going to be? This is an office visit. Like you can go ahead and say, all right, well, the problems is this, the data is this, and the risk is that. So therefore, this is my, yeah. Vina just said it. Vina just said, I just think it's moderate. Um, I do too. I didn't put the rest, this hypoglycemia and lightheadedness, because we didn't have any room. See, so sorry about that. But the data was extensive and the risks are here. But I guess I could have pulled it down. But we have diabetes type 2, CKD stage 3, hypertension, fatigue, edema, dizziness, hypoglycemia, hypoglycemia, and lightheadedness. And then the data was quite extensive. External nephrology records, reviewed prior hospital records, reviewed the CMP, A1C, renal function studies, ordered a repeat CMP, ordered a repeat BMP, even though it says repeat. I don't see no repeat. I didn't see it up here. In order to repeat your analysis, and they had a discussion with the nephrologist, and then the risks were insulin adjustment, modifies diuretic therapy, and close monitoring. So now I'm going to turn my attention to the tool, and I just want you to just trust that I'm putting in the um, what we've documented, and also you really can't um, put too much in there. It is limited. All right, so the date of service, let's just make it 2025, right? And let's say it's the 30th in 2025. Now, the type of service, it's important that you know the type of service. So you have to know, this tool won't tell you. So this was an office visit, right? So it's an office visit and it is an established patient, right? So there's a question. It says, was this encounter that fits the description of an office or outpatient visit that does not require the presence of a physician or qualified healthcare provider and therefore cannot be measured by time or medical decision such as a nurse visit? So no, this is not a nurse visit. So let's go. Now it's time for us to do the medical decision making, and we're going to begin with the problems, right? So where do we fall? And let me go ahead and just remind you that this patient had diabetes. The patient also has CKD stage 3. The patient also has HTN. They had hypoglycemia and lightheadedness, fatigue, edema, and dizziness. So I'm going to say that we have 2 or more stable chronic illnesses just for now. Now let me keep going. Um, if anyone wants to challenge and say, "Hey, I think it should be, let's go and look at the problems in the um let's see. Uh, I think it's two or more stable chronic illnesses. Hmm, there's no mention of exacerbation, just worsening fatigue. So if we're saying exacerbation, that would have to be pertinent to the CKD, that condition is exacerbated, or the diabetes mellitus. But this patient has um, hypoglycemia and lightheadedness. What do you think, Mr. Sandeep? Do you think that it should be? It's definitely not severe exacerbation because the provider did not document that it was severe. So I'm just giving it two or more stable chronic illnesses. That's where I am. And this is subjective, coders. All right, let's go. Now the problems, they want to know the prior external notes from each source. So we have one external nephrology record, right? There is no other record. However, there is a nephrologist discussion. So we have one external note, and they want to know the results, review the results of each unique test. Well, they reviewed the CMP, the HbA1c, and the renal function study. So that's three. And then they want to know which test they ordered. So they ordered a repeat CMP, they ordered a repeat BMP, and they ordered a repeat urinalysis, and that's three. Then for each category in analyze data, select the box. So was it, do we have an independent historian? No. Did we have independent interpretation of a test performed by another physician, other qualified healthcare? No, but we did have a discussion, right? That's it. And look, it's keeping your total right here. So we got 8. All right, so now we're in the risk section. And the risk is this patient's medication was managed. So I would say prescription drug management. I would also say that close monitoring took place, if that is, no, it's not that, not for toxicity, but close monitoring for to the risk of electrolyte imbalance and renal function decline. So that's all I have. So the MDM is moderate. It says it's moderate. So this is a moderate, and I'm going to save it. It's moderate, and it gave this. It's outpatient hospital, established patient, moderate. The data was extensive. The risk was moderate. So therefore, the entire encounter is moderate, and they coded 99214. Yeah. So, yeah, so you guys did an amazing job. Amazing job. All right, so I wanted to show you that. Now let's go ahead and close it out. And this AAPC tool is free. So definitely go to the tool and use it, practice it if you intend to use it for the exam. I might be like Ms. I might be like Ms. Vina. I might do it myself because I just think it's just easier. Boom, boom, boom. But if you want to use it, it's there. Some people are just kind of like, it might ease the anxiety, you know? So definitely use the tool. Okay. But you see, you have to be able to nail the location. You have to be able to um, know if it's an established patient or not, right? All right. So I just want to say, if you got anything correct, That's outstanding. It is. It is. And if you learn something, it's priceless. And I want you to go to Mr. Sandeep's class on Friday because you will. I hope you guys are doing E&M. I hope so. I don't know. Mr. Sandeep, you can let us know. And also, I would definitely, even though we have this calculator, learn how to score by yourself. It will give you the confidence that you need to take this exam, even if you use the tool. All right. So I just want to leave with how to study for the exams is found on your syllabus. So you don't have to say, oh, I got to look at the playback. Everything is at the bottom of your syllabus. And if you want more instruction, you want that AMCI experience, go ahead and take our classes. You have parts 3, part 2, whatever you need. You don't need part 1. So don't do it. And they're really, really cost effective. And how to study for or exam prep is on your syllabus at the bottom for all 3 certifications. All right. So just want to tell you that you all were amazing. We enjoyed you. There is no homework. Just go ahead and exam prep or review anything that you might need to. If you are in the course, the gold course, we do have a bonus module for you, and it's pretty much medical billing, insurance, and business of medicine. And it's good. And your instructions on how to exam prep are in your LMS. Oh, and don't forget about the video catalog. If you need it, click on evaluation and management for more instruction. And final tips. Go to the Friday guidelines class. Go to the Monday ICD-10-CM guidelines class. Never use an encoder except that E&M calculator. You can use any E&M calculator. It's just good if you intend to use it for the exam that you practice ahead of time. Never ever use blind process of elimination. And remember, the 2026 guidelines will take precedence. Period. Don't even second guess yourself. All right. So thank you all. I went over, way over. Thank you all for just kind of hanging in there for 16 weeks, hanging in there for 23 additional minutes. And if you will, please complete the survey. Let us know what you want to see next. What do you want us to do? And I'm going to do something different because there's a presumption. I assume that you already are doing work on your own, right? So I don't want to repeat or duplicate what we already have. So please and thank you. Is that link hyperlinked? It doesn't look like it. So if it's not hyperlinked, just copy and paste it, put it in your browser, and I thank you in advance. I'm going to thank my team for showing up and showing out every week. Mr. Sandeep, Ms. Mills, Miss Haley, Miss Beth. Outstanding. Thank you to my interns. You all are amazing. Vina D, Miss Beth, Ms. Star Wars Girl. She's not here, but thank you to her. Thank you, Case. Is there anybody I could have missed? I apologize if I do. So someone says, how do we attend the Friday class? The link is on your syllabus, isn't it, Mr. Sandeep? You can just show up it's right here on YouTube. So you show up, it's there, but we'll get it on your syllabus if it's not. Great question, Mercy. Okay, everyone, you all were amazing. Thank you, Sonita. Thank you, Brenda Whiteside. Thank you, Health Messages. Thank you. Well, Vina, I already said thank you to you. Kabenga, thank you. I just want to say thank you to everybody. I want to call all of your names, but I can't. Tanya Cox, B. Frazier, Laterre, and there was a Letty. Okay, I think that's you. Janet, Lucky. If I missed you, I apologize. All right, everyone. Signing out.
3,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all